Tawfiq gave you some of this already, and I apologize for repetition. Tell my kids repetition is learning, so here we go again. You have seen this table multiple times today, and just reinforcing how Crizotinib and Ceritinib are approved. We're expecting Alectinib to have approval soon. Brigatinib and X396 are moving into phase 3 first-line trials, and the Tesaro and the Pfizer compound are earlier on in clinical development. And what seems to separate these drugs, as Tawfiq mentioned, is they seem to have efficacy against different mechanisms of acquired resistance. And ALK is more complicated than EGFR. With EGFR, we know that 50% of people will be resistant and have T790M, while with ALK, the mechanism of resistance is a lot more dirty. And so figuring out these drugs will become a bigger and bigger challenge, and figuring out the brain is continuing to be a challenge. Now, what we know is that the brain is a common site of progression in patients who have ALK-positive lung cancer. And 15 to 35% of patients will actually have CNS disease at the time of their initial diagnosis, not necessarily symptomatic, but something that we might see on a CT scan. And the prevalence of CNS disease can increase over time, and more than half of the patients who are on Crizotinib will have the CNS as their first site of progression. And these are just different examples of brain metastases that we can see in the brain, in the spinal cord, and a patient here with leptomeningeal disease. In the trials that Tawfiq alluded to, Profile 1005 and 1007 were the second and third line trials with Crizotinib. And what we saw was that in patients who had progression on Crizotinib, almost 70% of patients had progression in their brain as the first site of disease. And this was regardless of whether patients had disease that was previously untreated, so had not had radiation to their brain, or patients who had had previously treated brain metastases. What we also learned from this review was that in patients who had baseline brain metastases, the Crizotinib was effective, and that we did see some responses both in patients who were previously treated and patients who were previously untreated. In these waterfall plots, the longer the curve goes down, the bigger the response. Whoops, sorry. What did I do? And probably the difference that we see in the response has more to do with the fact that patients who already had brain metastases had disease that was under control, while untreated patients had a larger margin where their tumor could potentially shrink with therapy. Also looking at Crizotinib in the first line, Tawfiq already presented this slide with Profile 1014, and this was the first line study looking at Crizotinib compared to chemotherapy in patients who were ALK positive, showing an improvement in progression-free survival. And recently we had some data at World Lung looking at intracranial disease control in patients with brain metastases at baseline. And we can see that patients who were on Crizotinib had higher disease control compared to patients on chemotherapy, both at the 3-month and as well as the 6-month mark. And how did this relate in terms of time to progression? We can see that in patients who have brain metastases at the beginning of study, their time to progression on Crizotinib was longer, being 15.7 months, compared to patients who got chemotherapy. But if patients did not have brain metastases at baseline, their time on both drugs appear to be fairly similar in terms of benefit within the brain. What about in the real world? Part of the problem is we all go to meetings and get up on the podium and present these large phase 3 trials, and here's the data. But patients enrolled in clinical trials tend to be a very select cohort. There tend to be people who are a little healthier, people who are able to travel often longer distances, people who maybe are willing to stay for extra blood work and testing, et cetera. And so there was also a presentation looking at a chart review of 147 patients from the United States and Canada. Now in Canada, Crizotinib is not approved first line, so you could only have got Crizotinib if you've had chemotherapy. And patients received Crizotinib first line or later line. And in 33 patients, they found that brain metastases were present prior to or at the time that they initiated Crizotinib. Now, they looked at the response rates, and the response rates, whether patients had Crizotinib first line or later line, were very similar at 60%, and we know that this is similar to what we see with trial data. And patients who were on Crizotinib first line seemed to have a likelihood of maybe staying on the drug a little bit longer, which we know that this is also true from the different phase 3 trials that have been done in Crizotinib in various lines of therapy. But what they also found was that Crizotinib, whether patients had been treated first line or second line, was able to induce a response. 41% of patients having a partial response, 18% complete response. This is fairly high, but 58% of patients having some sort of response if they had first-line therapy, compared to 44% of patients if they had second-line therapy. And some patients progressing, we know that that happens, that sometimes the response in the brain is not what we see, similar to the response systemically, and then also quite a lot of patients having stable disease. Now, moving on from Crizotinib to some of the second-line therapies that Tawfiq mentioned, what we think about the second-line therapies, and time will tell, is we think that they have higher CNS penetrance. We think that they're active against different mechanisms of acquired resistance to Crizotinib. And currently, Crizotinib is approved for patients who have progressed on Crizotinib, but other ALK inhibitors show very promising results. And so just to go over some of those trials and some of the results that we know so far. So first, Crizotinib, and Tawfiq already showed this, in ALK-positive patients, again, a waterfall plot, where below the line we consider patients to have disease, either a response, and a response in a lot of these studies is a 30% reduction or more in tumor, and progression is 20% growth or more in their tumor. And you can see that the majority of patients on Crizotinib falling below the 30% mark, whether or not they'd had prior Crizotinib or no prior Crizotinib. There was also data that was presented last year showing response rates in the CNS in patients, and they had 124 patients, so a fairly large cohort of these patients who had brain metastases at the time of study entry. And this is probably because a significant number had had prior ALK inhibitor treatment, 98 patients, compared to 24 patients who were ALK TKI naive. And when you look at the response rates in patients with brain metastases, the overall response rate was 50% in patients who had had prior tyrosine kinase inhibitor. It would have been Crizotinib, compared to 69% in patients who had not had a prior tyrosine kinase inhibitor. And these patients also had a fairly good progression-free survival, so were on the drug for a fair amount of time, 6.5 months for patients who had had prior Crizotinib, compared to 8.3 months for patients who had not had prior Crizotinib. Moving from Crizotinib to Alectinib. Alectinib is another second-generation ALK inhibitor. The ALK study was the first-line trial comparing Alectinib to Crizotinib in ALK-positive patients, and that trial is now close to enrollment, and maybe we'll get some data a year from now. But this drug is approved in Japan, and the initial phase 1 trial showing, again, a very promising response rate of 53%. Sorry, this doesn't project as well as it did when I was looking, for patients on Alectinib, and a median duration of response 13.5 months. When we looked at the CNS responses to Alectinib, again, a complete response seen in 25% of patients, but 100% disease control. So the remainder of the patients not necessarily having a complete response, but also not having growth of their disease. Now, this is a small group of patients, only 16, and these patients had to have a tumor that was a centimeter or larger in order to be considered to have measurable disease. They also included patients who had non-measurable disease in this analysis, and saw that, again, the disease control rate was in the range of 88% for all patients. When they looked at whether or not folks had had radiation previously, the response rate was higher in patients who had had no prior radiation, 67%, compared to 26% for patients who had had prior radiation. But again, the lack of response in prior radiation does not necessarily mean that the drug does not work if you've had radiation. If you look, the numbers here add up with a large proportion of patients having stable disease, which is similar to the proportion of patients, if you add these numbers up, who had had no prior radiation. It's harder to measure a response if a patient's already had radiation, because the radiation itself is effective in treating brain metastases. Moving on, and I only realized after this, I downloaded this from a website, but it then saw that it said draft on it, so I apologize. But Brigatinib in ALK-positive lung cancer, Again, a wonderful drug, a great waterfall plot showing the majority of patients having a response to therapy. And when they reported at World Lung this year, the CNS response rate in patients with measurable disease, 53%. And if you included complete responses, partial responses, as well as stable disease, so no growth of disease, similar to alectinib at 87%. And if you included patients with non-measurable disease, again, that requirement that patients have a tumor greater than a centimeter, the response rate goes a little bit higher, up to 94% for patients having disease control. So to confuse you with another ALK inhibitor, as Tawfiq mentioned, this is my favorite drug, only because we've been very involved with this compound for several years now at Vanderbilt, X396. And this is another second-generation ALK inhibitor that's currently in phase 1 trial, but will soon be going to phase 3 in comparison to Crizotinib. And the recommended dose going into phase 3 is 225 milligrams daily. And this is data on patients treated at the dose of 200 milligrams daily or higher, showing again, a response rate of 91% in patients who had been treated with prior Crizotinib. And there has been patients with CNS disease, smaller numbers. There have now been 3 patients with CNS disease, with measurable disease, who we've seen responses. And we continue to enroll in this trial for both patients who are treatment naive and have not received prior Crizotinib, as well as patients who have had Crizotinib in the past. This is the waterfall plot, again, seeing a nice response in patients who have both been on prior Crizotinib as well as Crizotinib-naive patients. And this is some preliminary data showing duration of response. Early patients, the patients at 2 months, are all these patients are still on study up to 25 months. This is just one patient who went on the original study, and this picture actually hung on my door for about 2 months. My boss was so excited. This is one of my patients who had been on Crizotinib for about 2 years and had progression both in her CNS as well as progression in multiple areas of the lung. And this was her PET scan after 5 weeks on X396, as well as an amazing scan result within the brain. And she still remains on study now at 25 weeks. And this is another patient who a colleague was nice enough to send me the scan, try to circle where the CNS disease was here, who's now been on 396 for 7 cycles. And after the first 8-week scan, seeing a really nice response, 83% reduction in brain metastases on 396. So we know at this time that Crizotinib is standard first-line therapy for ALK-positive non-small cell lung cancer, and it does have definite but limited CNS activity. In newly diagnosed ALK-positive patients with small asymptomatic brain metastases, we used to think that we should radiate them and then put people on Crizotinib, but we now know that Crizotinib is a reasonable option prior to radiation with close monitoring of the CNS. And for my patients, I scan, if they have untreated brain metastases, I scan their brains as often as I scan their chests. Second-generation ALK inhibitors have shown promising and durable responses in patients with CNS disease, and the role of these agents in the first-line therapy is currently being explored. One of the secondary endpoints of the ALEX trial is looking at time to failure within the brain, and that is also one of the secondary endpoints in some of the other trials comparing Crizotinib to second-generation ALK inhibitors. Thank you for your time.